Okay, so we are back to do the final portion of our Learning Plan 1. And this is regarding mental health disorders and pharmacology. So I did just want to clarify from our last lecture on neurotransmitters that there are 6 neurotransmitters, but the ones that are most commonly associated with mental health disorders were the norepi, the dopamine, serotonin, GABA, and glutamate. So I know I kind of confused you a little bit during that lecture when I said there was 4 and then I later said there was 6. There are 6, but these 5, excuse me, are the ones that are most associated with mental health disorders. I also wanted to mention that if you're a visual learner and you find the transmitters and the neuron progression a little bit confusing, there is a video that shows the animation of this occurring, and that is on Blackboard under your view folder. So you might want to look at that, and that might help clarify things a little bit more for you. So now we are going to move into the pharmacology of mental health disorders. And we're going to start with our anti-anxiety or antioxylytic drugs. And what these drugs are is they are targeting that GABA neurotransmitter. So by giving anti-anxiety drugs, what happens is these drugs fill the spaces of the receptors so that there's more GABA that can be used to slow down the next neuron transmission on the postsynaptic cell. Okay? So it has that calming effect by blocking or using those neurotransmitters. So right here, if you look at my cursor, so here's your anti-anxiety medication. It's going to take up the space on this receptor, which leaves GABA freely open to pass through and slow down this transmission along the postsynaptic cell. Okay. So if you have increased GABA, it's going to increase anxiety levels. It's going to increase your sedation and muscle relaxation, and that's what we are looking for. Increased effectiveness of GABA then impedes the sending alert signals to the next nerve. Okay. Now, there are several side effects that do occur because of these benzodiazepines, and some of those are dizziness, lightheadedness, and perhaps a change in personality. So the benzos bind to the receptor, promoting the activity of the GABA. And in older adults, we have to be really careful because the use of benzos actually has been found to contribute to falls and thus secondary broken bones. So the use in the elderly is minimal. Ataxia is also a common side effect, and that is secondary to the abundance of the GABA receptors in the cerebellum. Decreased excitation and the calming effect also helps with anticonvulsions and alcohol withdrawal. Okay, some examples would be Valium, Klonopin, Xanax, Ativan. These medications can be very addictive, and they are only prescribed on a short-term basis, like a PRN basis. They're never scheduled, and they're only to be used for a short period of time just because of the addictive nature to it. So when we're doing our nursing assessment, we have to be very concerned about oversedation, our respiratory status, slurred speech, drowsiness, changing position and hypotension, those kind of side effects. So when we're educating the patient, we're educating them to be careful with their activities that require concentration, like driving. When used alone, even in high doses, these drugs rarely inhibit the brain to the degree that respiratory depression, coma, or death occurs. However, when used in combination with other central nervous system depressants such as alcohol or opiates, antidepressants, the inhibitory action of the benzo could lead to life-threatening central nervous system depression. So we are always educating the patients on not using alcohol while they are taking benzos. The next category are antidepressants, and there are four main antidepressants that are used. They are SSRIs, which are select serotonin reuptake inhibitors, SNRIs, which are select norepi reuptake inhibitors, tricyclics, which actually are blocking agents for norepinephrine and serotonin, and then the MAOI inhibitors, which inhibit that monoamino oxidase enzyme. So we'll talk about each of these a little bit. The SSRI blocks the reuptake and destruction of serotonin. Drugs, so if you have a deficiency in one or both of these monoaminos within the limbic system, produce depression. So in essence, what they are doing, both the SSRI and the SNRI, is inhibiting that reuptake of the neurotransmitter from being destroyed by the MAO enzyme, leaving these neurotransmitters more abundant and able to be used. Okay? Tricyclics, what they do is they block. Okay? They don't inhibit the reuptake. The tricyclics block the reuptake and destruction. Okay, that is the difference. They're a blocking agent. They are not prescribed very often, and they're not used as a first-line medication for depression. Your SSRIs and your SNRIs are the preferred treatment as antidepressants than the tricyclics are. Tricyclic antidepressant overdose can be fatal, secondary to the cardiac conduction disturbance from the excessive sodium channel blocking components that it exhibits. Okay. Now the MAOI, I say that very carefully because I always mix up the A and the O, so I say it very carefully. The MAOI inhibitors, what those do is inhibit the monoamino oxidase enzyme that destroys other neurotransmitters, right? So it gets rid of the monoamino oxidase, so it no longer can destroy other neurotransmitters like the serotonin, norepi, dopamine, etc. So it gets rid of that. These drugs are they are not prescribed often. They are the last drug to be used of all the antidepressants. It's like if you have tried an SSRI, an NRI, and a tricyclic, and none of those modalities are helping alleviate the symptoms, they will try an MAOI inhibitor, okay? And the reasoning is because this drug is very dangerous. It is affected by diet, specifically tyramine in the diet, and it also, what am I trying to think here? It also interacts with multiple other drugs that cause terrible side effects. The number one side effect related to this drug is hypertensive crisis. Okay, so if you have too much tyramine in your diet, or this drug interacts with the 115 other drugs that it's incompatible with, you will end up with hypertensive crisis. Okay, so MAO is needed in our body, in the liver, to break down other substances that enter our body through food and drugs. So this causes an increase in monoaminotyramine. So if we have tyramine in our diet, again, that's going to cause an overload of tyramine, and it will cause this hypertensive crisis. So if we inhibit the MAO and increase the tyramine levels, that's when we get into danger. So foods that contain tyramine are things such as aged cheese, pickled products, smoked products, wine, just to name a few. So these people who are on these drugs, the inhibitor drug, have to be on a very cautious diet related to this. Oh, I didn't advance the slide. I'm so sorry. You can see in each of these I've provided some examples of medication names. You can review those. So let's look at the neurotransmission part of it, okay? So we have tricyclics and select serotonin reuptake inhibitors. Remember, these are inhibiting or blocking, right? So I think we get the inhibiting part. So if you have serotonin here and it cycles back, let's just not think about that green square there for a minute. This cycles back, and the MAO destroys the extra serotonin. So what the inhibitor does is it stops the MAO right here from destroying the extra serotonin, and it allows it to re-enter the presynaptic cell and be utilized again. Now, what is being depicted here with this Prozac is the brand name of this drug. So this is a tricyclic, and remember, tricyclics don't inhibit, they block, right? So here's your tricyclic drug right here, and what it does is block this serotonin from being taken back up to the MAO. So it keeps it in this synapse area here so it can be reutilized. So that's the difference there between the blocking of tricyclics and the inhibition inhibition of the reuptake that you see with SSRs and SNRs. Okay. Now here is a depiction of what the MAO is doing. So if you give a MAO inhibitor, oh no, what happened? Okay, I don't know what happened. Go back, go back. Oh, where am I? Okay. Oh, I guess it just booted me way ahead. Okay, so here we are again. If you have an MAO inhibitor, what's happening is that drug is actually destroying MAO. And if it destroys it, this cycle where the neurotransmitter comes back, it can't be destroyed because we've gotten rid of the MAO, so it goes back into the presynaptic cell to be used again. Mood stabilizers, an example would be lithium. What's thought to happen here is that there's overexcitement of the neurons, which can cause conditions such as like bipolar disorder. And what they think is that lithium interacts with this complex interaction between sodium and potassium, and it helps to stabilize the electrical activity of the neuron, and therefore essentially slows down that neurotransmission. Okay, lithium is a positively charged ion, so because it's positively charged, it interacts with that sodium-potassium exchange, remember, and it stabilizes that electrical activity. Now, um, lithium can be a very toxic drug. By altering the electrical conductivity of the cell, the lithium represents a potential threat to all other body functions. So too much lithium can cause cardiac problems such as sinus bradycardia. It can cause extreme alterations in cerebral conductivity. So with overdose, it can lead to convulsions. It alters the nerve and muscle conduction and can lead to tremors or other extreme motor dysfunction with overdose. If a person has hyponatremia, this can increase the risk of lithium toxicity because the kidneys are going to attempt to reabsorb that sodium, which essentially leads to increased reabsorption of lithium, also causing toxicity. Hypothyroidism has an effect. It secondarily interferes with the iodine molecules, affecting the formation and conversion to thyroid hormone. So lithium is absorbed in the GI system, and the renal system, again, because of that sodium concentration, it can reabsorb rather than excrete the lithium, causing higher levels. What does this mean for us? It means that we have to check frequently what that lithium level is for these people. So the normal lithium level would be 0.4 to 1.3. So oftentimes we're doing frequent blood testing on these patients to test that lithium, to watch that lithium level, okay? If we're assessing the patient without any blood serum testing, what we would be looking for with lithium toxicity would be frequent urination, edema, tremors, the bradycardia, and convulsions, okay? We also are going to be wanting to monitor that sodium level, and if the patient is hyponatremic, they would be at high risk for toxicity, as we mentioned before. So this is another one of those drugs that we use for mental health that can be very dangerous for the patient. Antipsychotics. So what antipsychotics do is they're targeting dopamine. They are blocking the action of dopamine, okay? So it's thought that overactivity of dopamine in certain areas of the brain may be responsible for some of the symptoms of schizophrenia. So by blocking dopamine, what we are doing is reducing those positive symptoms such as delusions and hallucinations in our schizophrenic patients. What it does is it binds to the receptors and blocks the attachment of dopamine. So again, if you look at my cursor, we have dopamine that is coming out, being available. Our antipsychotic drug here is going to block this receptor, and it will make it so that the dopamine is not used, and it will slow down this progression here in the postsynaptic. Okay, so it binds, the antipsychotic drug binds to the receptor and blocks the attachment of the dopamine, and it reduces the dopaminergic transmission. Okay. So antipsychotics can be categorized into typical and atypical. The typical one we just talked about, that's the dopamine antagonist, okay? And the atypical is it actually is blocking dopamine and serotonin. Typical antipsychotics like Haldol are not used so much anymore, and because they come with many side effects. Okay. The atypicals are now being prescribed more often. Risperidone, Seroquel are some of the common ones because they produce less extrapyramidal side effects. And what are extrapyramidal side effects? Those are the things when we were talking in our assessment, we were using the Ames scale to watch for these extrapyramidal side effects. Parkinsonism and the involuntary muscle movements with akinesia, the irregular or rhythmic kind of motions with that's a hard one to say, akaesthesia, and then the tardive dyskinesia is another one of the side effects that we're watching for. Excuse me. So the atypical drugs are being used more and more. Now there are a couple that I want you to, so they decrease the extrapyramidal side effects, but on the other hand, they have their own side effect, which is that they increase weight gain, they increase glucose levels, and they increase triglycerides, which are a negative side effect. So, you know, you always get the good, but then there's always bad too. So a couple of the antipsychotic meds that I want to draw your attention to, clozapine, excuse me. This drug has the potential to suppress bone marrow. Because of this, any deficiency in white blood cells will leave the person more prone to serious infection. So another lab that we're commonly drawing on people who are on this drug is their white blood cell count. This count is going to be measured weekly for about the first 6 months that the person is on the medication. And then after that, every other week for the next 6 months, and then taper down to monthly thereafter. Okay? Risperidone is the other drug that I wanted to call your attention to. It has the highest risk for extrapyramidal symptoms. And it can increase prolactin. What that means is that it can lead to sexual dysfunctions, amenorrhea, production of milk from the breasts. It can cause those types of symptoms. It also causes orthostatic hypotension, and it's actually been found to prolong the QT interval, which opens up a person to cardiac abnormalities. There are many, many, many other side effects of antipsychotic medications, okay? Because it also blocks the mucarinic or affect a muscarinic blockage, it affects acetylcholine. And so what you're going to see from that is these patients will have very, very, very dry mouths. And you're going to want to offer them some dry candy, gum, or water frequently to offset this side effect. It also will cause constipation in these patients. Okay? We kind of already talked about the blocking of dopamine and the effect on the extrapyramidal symptoms. Parkinsonism is when people have like a mask-like face. They're very stiff and stooped over. They'll have like a shuffled gait. They may be drooling, have tremors. The akinesia is the absence of voluntary motion. The akaesthesia is it's that regular rhythmic movements, usually of the lower limbs. So an example would be restlessness, pacing, tapping of the feet, rocking back and forth in a chair. Okay? Tardive dyskinesia is a serious and irreversible side effect. It is involuntary tonic muscle spasms involving the tongue, the fingers, the toes, the neck, the trunk, or the pelvis. So an example would be protruding of the tongue or rolling of the tongue or continually blowing or smacking or licking the lips. So there is no treatment for tardive dyskinesia. Again, I think I already referred you to watch the videos that are posted on Blackboard that show you actual people displaying these side effects so that you can visualize what that looks like. So again, please watch those. Cogentin is a drug, and Benadryl is another drug that can be used to treat all of the other extrapyramidal symptoms and help them go away, but not the tardive dyskinesia. So when we are teaching patients about antipsychotic medications, it is essential that we are telling them that they need to report any muscle changes, muscle movement changes, or stiffness. We're educating the client that they should eat a diet high in roughage to offset the constipation. We're educating the patient to rise slowly when getting out of bed because of the hypotension side effect. The clients who are experiencing dry mouth, again, we're offering the sugarless chewing gums, the sugarless dry candies, and increasing their fluid intake. Okay, so that completes this learning plan and the pharmacology of mental health. So, congratulations, you got through it. And I got through it without coughing too much.